Well, let me kind of go ahead and get started and make sure we acknowledge everyone's time. Welcome, everyone. I'm Dr. Joseph Sirven. I'm a professor of neurology, a chair emeritus of the Department of Neurology at Mayo Clinic in Arizona, but I'm also a professor of practice here in the College of Health Solutions at ASU, where I teach in the science of healthcare delivery. I have had the pleasure with my wonderful colleagues, Dr. Greg Meyer, Dr. Swapna Reddy, co-creating and moderating podcasts. We Need to Talk, Tough Conversations in Healthcare, that was produced by Arizona State University. I am now also, while being at ASU, but I'm also Neurology Core Clerkship Director for the Mayo Clinic College of Medicine and Dartmouth Medical School at my practice at Mayo Clinic in Jacksonville, Florida. I want to thank you for joining our Health Talks webinar, who's brought to you by the College of Health Solutions here at ASU. And our college, it's the main point is to basically help address the challenges facing people and communities to stay healthy, improve their health, and manage chronic disease. And if you just turn on the news on any day, my goodness, that is all we're talking about lately when it comes to these issues. Now, these health talks are one way that we serve the community with timely and relevant educational information that helps to also provide continuing education credit at no cost. So a couple of quick housekeeping items. First, the session is being recorded and it will be posted on our website at asuhealthtalks.com. Now, after we've had the chance to present, I'll moderate a Q&A session on this platform. And I want you to submit your questions using the Q&A feature and not the chat box. So check under the Zoom box. There is a specific Q&A box feature right there that you can put your question in so that we can get to it. And finally, you're going to receive a brief survey asking for your input about today's webinar. And we really appreciate your feedback because we always want to improve our series, make sure that we're hitting the sweet spot in terms of what you need and what you can use for your everyday lives. Now, today we are going to be talking about the highs and lows of medical marijuana. I love that title, but I'll leave it there. I'm going to be offering our first presentation today. It's more of an overview, medical overview, if you will. And then I'm going to be followed by Dr. Jason Scott Robert. Dr. Robert is the Dean's Distinguished Associate Professor in the Life Sciences at Arizona State University. His teaching and research are at the intersection of bioethics and philosophy of biology, with a particular focus on the justification of controversial research, especially in the neurosciences. Now, Dr. Robert moved to ASU in 2004 from the philosophy department at Dalhousie University in wonderful Halifax, Nova Scotia, in Canada. He earned his PhD in philosophy at McMaster University in Hamilton, Ontario in 2000, where he also earned his MA. His undergraduate studies were at Queen's University at Kingston, Ontario. So we're so fortunate to have Jason with us today as we explore, it's 420 somewhere, the highs and lows of medical marijuana. So let me kind of get to one of the main points today, which is, what about medical marijuana? Well, let me give you my 2 cents worth as we kind of get this going. When it comes to medical marijuana, it can be very difficult for a clinician like me and others to differentiate truth from hype. So you can imagine how it feels for anyone out there. The questions that everyone's always asking me is, how useful is marijuana to relieve patients of pain, nausea stemming from health conditions? What are the ethical implications of medical marijuana for healthcare professionals? And how can they navigate the controversies linked to marijuana? You know, as one of the things that always strikes me is like, I am here on the other side. I've had the perspective of not only getting to be with Arizona State, but living in Florida at the moment. What's interesting is watching how anywhere I go, there is a dispensary or new dispensary opening on my corner. Just about 6 weeks ago, there was a deal struck with some legal benefit, if you will, from the state of Florida to allow for CBD, one of the things I'll be talking about, to be sold at Circle K gas stations throughout the state of Florida. Now, if that isn't a way of Bill and Ted's Excellent Adventure coming to life, I don't know what is. There is truly something strangely afoot at the Circle K here in this state. But that's one example, and that's one of the issues that we're finding ourselves with. So let me kind of help to provide some of that background, if you will. So I'm going to share my screen for a moment. And I want to basically start off, and as I kind of pulled it off from the very beginning, is that there are medical uses of CBD. In fact, one of the things that I think students and people are always surprised to find out is that humans have always found marijuana or cannabis in history. It dates back to more than 8,000 BC, starting in China, where it was used in rope, cultivated, used for garments, bowstrings, paper, and medicine in China. At 2700 BC, it had even medical utilization for things from menstrual periods, gout, rheumatism, malaria, constipation, and absent-mindedness, whatever that means in that time. By the 1st century AD in China, it was used for more than 100 ailments. But China wasn't the only place. It had medicinal uses in ancient Egypt, India, Africa, Greece, Rome, and the Arab world overall. Now, one of the things that you have to start out with when we say the word cannabis or marijuana is that it's really, we're talking about a plant, and the plant has lots of compounds in it. So the two plants that often come up are cannabis sativa, which is the oldest known species used by humans, again in China, with about 420 different compounds as part of it. These are kind of some of the ones that we listed out here. And then there's 80 terpenophenol compounds or cannabinoids that can be sorted out. So we're talking in multiple hundreds of different variations of what you could produce from the one plant. Now, cannabis indica, that's referenced in ancient Vedist texts in India, dating back to 1700 BC. Now, what's interesting about these is that they have, it really becomes a story of what are the two big principal compounds we worry about, which is the cannabidiol or tetrahydrocannabinol, THC versus CBD, and they have two very different properties in the body. Now, the sativa plant has a high THC to CBD range. THC is the more psychoactive version, while CBD is more quieting and more sedating. So that's where it kind of took its life. Now, sativa has, as I mentioned, the psychic and stimulatory properties, while the indica strains are much more sedative. There is a more, interestingly enough, and it's always fascinating when you learn this in general about the human body, is that there is a set of receptors for cannabinoids. So somewhere in our design, if you will, there are an endogenous cannabinoid system that have very particular activities neuronally, particularly as it responds to different variations on these. And these compounds bind to these receptors differently. Now, the use of cannabis stems back in the United States, back from 1854. And this was back, as you'll see listed here, neuralgia, depression, hemorrhage, pain, and muscle spasms. The Ohio Medical Society Committee on Cannabis, 1860, time, like we're talking Civil War times and right before it, the efficacy for neuralgic pain, dysmenorrhea, delirium, mania, whooping cough, infantile convulsions, nervous rheumatism, chronic bronchitis, tetanus, epilepsy, and appetite stimulation. Again, the two main plants based on their THC or CBD compounds are the sativa and indica, and the sativa was the one that they found mainly affected the mind. That's the tall and skinny plant, the uplifting and the euphoric feeling, the one that people would tell the jokes about, while indica is the more high CBD range, mainly affects the body, has slightly different plant look, heavy feeling, more sedating more than anything. Just to give you a sense that this is like circa 1945, there was a tax stamp in the US for growing marijuana. Now, cannabis was originally listed in the US Pharmacopoeia from 1854 to 1941. For those who may not know, the Pharmacopoeia is basically the pharmaceutical catalog for what's approved for use medicinally in the United States. It was officially removed in 1942. And we got there because of this gentleman. This is Harry Anslinger. Harry Anslinger in American history was the first director of what was to become the Drug Enforcement Agency of the United States, or the DEA. Now, one of the things about, at the time, we were in a depression in the United States when this was happening. There was a lot of growing of cannabis. It was becoming super popular, and it started frightening people. And this gentleman in particular felt that we need to do something about it. The reason I bring up the depression is because they also needed to make money. So they thought, let's tax this. But they taxed it to a degree that it killed it, technically. And then, with the help of William Randolph Hearst, he basically went out and started talking about how this was poisoning everyone's minds. And without getting into a long discussion, started using racial issues and immigrant issues to kind of say that's where this is coming from. And it got criminalized. Next thing you know, and that's that. It went from there, and the research we'll hear about in a moment kind of stopped when that's the case. So that's where we got. It wasn't until more recently that people started kind of doing a grassroots movement, pun intended, to basically find a way to research and see, can we do this? But that was a lot of trouble to make that happen. So if we look at where we are medical uses of cannabis now, as I said, there's THC and CBD, and there are some things for which we know that we can use this for. In pain management, it's been shown to reduce chronic pain. It does not have necessarily an indication for this, but it does have at least a sense of people utilizing it on their own from dispensaries for that purpose, and it may have utility, particularly for just very difficult to manage pain. A lot of cancer pain comes from this as well. Anxiety and depression. This is now being utilized in things from post-traumatic stress or any type of depression. The question is, again, there's not a clear indication from this from the FDA. There isn't a drug trial that has come out, which there has been for one condition that I know of. And this is one of those areas that it could have roles with. In my area as a neurologist, CBD has been a big deal. CBD, one of that compounds, in its purified form is now marketed under the brand name Epidiolex. It got a formal FDA indication as a medication, as a treatment for very difficult to manage epilepsy. Now, this is for 99% purified CBD. It's grown at a undisclosed location in Ireland, and they charge a fortune for this if you don't have insurance. But if you have insurance, it's well covered. But they have to have the precise type of epilepsy to have this. There are side effects. There are drug interactions. It is a med, so this isn't completely innocent, but it does have true utility, and it went down the same path as a traditional medication did. It's also being looked at for spasms of MS and also to help in Parkinson's disease, amongst many other conditions, but it only has an indication in the world of seizures and epilepsy. In cancer, this has been around for a while. There is a version of it that's actually almost like THC-like, which has been shown to do two things. Number one, it helps some elements of anti-tumor effects, but more importantly, seems to be an appetite promoter. So for those people who lose a lot of weight because of cancer treatment, it helps to relieve some of that. I know many cancer patient who will use THC to help relieve some of the pain, the nausea, the misery that comes with it, and also to help promote eating. And that is also an FDA-approved version of a THC type of medication. So in general, as an overview, I wanted to point out there are real potential medicinal uses and benefits, but like any medication, there's no such thing as a drug without side effects. So you have to do risk-benefit analyses to decide whether this is the way to go. As for dispensary stuff, we'll talk about that briefly or answer questions, but I want to turn it over to Dr. Robert, who's going to make his presentations at this moment. I'm going to stop my share and turn it over to him.
Thanks very much, Dr. Sirven. I appreciate those really interesting and helpful introductory comments to get this conversation going. I do want to point out I have two disclosures to make. One of them is that nothing that I say here should be interpreted as me giving you advice to go ahead and start taking marijuana for any purpose whatsoever. Consult a physician or your friend group. I mean, either way, but don't take the advice from me. My second disclosure is I'm not legally allowed to use marijuana, whether recreationally or medically, given that marijuana is federally banned and I am a permanent resident, but not a full citizen. And so as a result of that, some of the things that we're talking about today are things that I think would be really interesting for me to be able to partake in, but I can't do that legally yet. I do want to point out to start off that there have been a number of public opinion surveys conducted over the last couple of years that consistently show that well over half of Americans believe that marijuana use is not just acceptable, but socially acceptable. That is, that smoking weed or consuming marijuana in another form is it's becoming normalized. And I've not heard a better example of that than CBD available at your local Circle K. At the same time, it's interesting that 70% of people who have tried marijuana at some point in their life support its recreational use. And so there is a strong support amongst those who tried it. Those who haven't tried it tend to be fairly adamant about it. But I will point out that only about a quarter of the people who don't use marijuana cite its legal status as the reason for not using it. In other words, I do want to suggest that that means that if marijuana is made more widely available, we're not going to see a massive uptake from people who don't take it because it's illegal. There are going to be other reasons that will stand in the way of us seeing marijuana become even more widely used. I do also want to point out that at least 3/4 of Americans seem to firmly believe that marijuana is less risky than tobacco, alcohol, and opiates, which of course goes against the kinds of things that Harry Anslinger had to say back when he was actively campaigning both in favor of the 1937 Marijuana Tax Act as well as other regulations. One of the things that he suggested in testifying in Congress in favor of the Marijuana Tax Act of 1937 is that it's an addictive drug which produces in its users insanity, criminality, and death. And he referred to it as worse, earlier he referred to it as worse than cocaine or heroin because it causes criminal and violent behavior. And that's a very interesting starting point, I think. I'm going to talk about the challenge of medical marijuana in the US today, and that is that we simply don't have the evidence that would be required to demonstrate medical utility, except in the rarest of cases like Marinol and the epilepsy drug that Dr. Sirven mentioned. When thinking about medical marijuana and recreational marijuana legislation, currently there's an absence of evidence about the safety and efficacy of marijuana for medical purposes. And on top of that, we've got this suboptimal regulatory regime. So absence of evidence is pretty straightforward. It's crystal clear that there are virtually no clinical trials showing safety and efficacy of marijuana for medical purposes. Now, on the one hand, that could be damning, right? Except that the reason that we don't have clinical trials showing safety and efficacy of marijuana for medical purposes is that we haven't conducted the trials that would be necessary to demonstrate safety and efficacy. It's not as if we have a wealth of clinical studies that show medical marijuana is unsafe and ineffective. It's just that we don't have any studies at all. And it turns out the reason that that's the case in the US, at least, is that the government has made it near impossible to conduct medical marijuana research. And that's because, as a result of the legacy of the kinds of activities of Harry Anslinger and like-minded folks in the 30s and 40s, the Drug Enforcement Agency classifies marijuana as a Schedule I drug under the Controlled Substances Act. Now, the reason it's a Schedule I drug is that there's no evidence of medical benefit. But this is a research catch-22. There's no evidence of medical benefit precisely because it's a Schedule I drug, and so it can't easily be studied. In order to study marijuana in a research setting, one needs to have permission from the FDA to conduct the research. And it turns out that it's very, very difficult to secure the kind of clearance necessary to study marijuana in a lab. There has been some progress in the last 5 years with regard to the FDA and the DEA making it a little easier for people to secure a Schedule I drug license for research purposes, but it's still not an easy process. Now, if you take a look at the DEA website, you'll find out what other drugs are classified as Schedule I. Heroin, LSD, ecstasy, methaqualone, and peyote are the other drugs listed as Schedule I. And if you look on that website, you'll learn that Schedule II drugs are drugs with a high potential for abuse, which is the same as Schedule I, and their use could potentially lead to severe psychological or physical dependence, and they're also considered dangerous. So it's possible you could classify marijuana in this way if you like, and those drugs include things like Vicodin, cocaine, methamphetamine, methadone, fentanyl, oxycodone, Adderall, and Ritalin. But at least for Adderall and Ritalin and oxycodone and methadone, immediately you'll recognize that we've got some medical usages that are widely approved, whereas for marijuana, you don't have that. And because they're Schedule II drugs, it's easier to study all of those drugs I just listed in a clinical setting. But marijuana can't easily be studied in any kind of setting, so we end up with this research catch-22 situation. It can't easily be studied because it's a Schedule I drug, and it can't be rescheduled because there's no medical evidence of benefit or no evidence of medical benefit. So this has been a big challenge, and there's an even bigger challenge associated with it, which is that despite the fact that over the last couple of decades, the US has invested a couple of $2 billion in marijuana research, it's not clear how useful that research is at this particular point in time. So why would I say that? Well, it turns out that the research, at least up until 2017, all marijuana made available for any kind of research had to come from one source, and that source is the National Center for Natural Products Research at the University of Mississippi. That would be the only source of the marijuana available for research purposes. So I'm going to call that federal weed. Okay, that's the the kind of weed that you're allowed to use in clinical research settings if you have a Schedule I DEA drug license. But it turns out that federal weed is nothing like the kinds of marijuana currently available in dispensaries in a large number of US states. The challenge is that the federal weed has a maximum available concentration of 12% THC. Whereas, and of course, if we're talking about CBD, it's a slightly different story, right? But if we're talking about THC, what the state dispensaries are dealing in is weed with an average of 15 to 25% potency of THC, as distinct from just 12%. There are even some products out there that have as much as 35% potency, and some really concentrated cannabis products that have 80% THC. This is completely unlike the weed that has been made available for research. On top of that, federal weed grown in this one location has often been frozen and then thawed before being shipped out, which has also led to some clinical studies with this federally approved marijuana producing, not even being able to get off the ground because the substance was tainted, or it had become moldy before even being made available for research purposes. So there was a move about 5 years ago to try to allow for a larger number of sites to provide their marijuana for research purposes with the approval of the University of Mississippi's National Center for Natural Products Research, but that's been fairly slow going to date. And so as a result, we don't end up having the kinds of data that would be necessary for us to make really good claims about the medical efficacy and safety of marijuana. So I want to make a controversial statement, which is that marijuana is not medicine at this point in time, at least not yet. There are some exceptions. We heard about them from Dr. Sirven. There should be lots of exceptions, and we should get to a point in the coming decades wherein we've got the kind of evidence necessary to demonstrate the medical benefits of marijuana. But at this point in time, we don't. And so we end up having a kind of gerrymandered system in place. I'll just relate a quick anecdote. Friend of mine went to seek out a prescription for marijuana to deal with anxiety and depression. And so he went to a clinic to see a physician and explained to the physician, I'm here because I'd like to be able to get my card so that I could purchase marijuana for my anxiety and depression. And the doctor said, okay, now how long has your back been hurting you? And my friend said, well, my back's not hurting me. I'm not here about that. I'm here because I've got these symptoms of anxiety. And before the doctor even finished, the doctor intervened and said, now tell me, what else have you tried for this back pain? Have you tried any other kinds of things? And eventually my friend caught on and said, oh, yes, I went for acupressure and acupuncture and various other things. Nothing's worked, doc. I really need something for back pain. And he got his medical marijuana card. I doubt that that's always the case or particularly representative, although it could be. Arizona is also interesting now because we've got recreational marijuana, the same kinds of drugs available without a prescription. They're just more expensive. And the taxation issue is higher for recreational use of marijuana. But I want to suggest that if basically physicians and patients have to engage in a kind of charade in order to provide access to something under medical conditions that hasn't yet been demonstrated to be medically beneficial or efficacious, then I want to suggest this is, we're almost making a mockery of medicine at this point by insisting on a distinction between medical and recreational use. I suspect that most people who regularly enjoy marijuana do it to help with medical issues, as well as with state of mind issues that could manifest in various kinds of behavioral problems. I commend them for taking advantage of what's available that might prove useful. But I really just think that we're at a point in time now where we really need to stand up and insist on the clinical studies that will, I think, as long as we're doing the studies with the kinds of weed that are available in dispensaries, the kinds of things that your bud tender gives you rather than the kinds of things that get shipped out from Mississippi. If we do that kind of research and we do it carefully, we'll be able to reap the benefits of marijuana for medical uses in the coming decades. In the meantime, I think that it's a fairly bad idea to not have the alternative of recreational usage made available, especially in those states that haven't seen fit yet to legalize this drug, which, as I point out, most Americans strongly believe is considerably safer than alcohol, tobacco, and opiates, all of which are readily available, even without a prescription. And that's all I wanted to say.
Thank you, Dr. Robert. That was very good, and you're right, provocative, yet I think right on the point. And maybe this is our moment then to try to kind of address some of the questions that are in the Q&A. A lot, I see that several have trickled in there, and they're very specific to certain things. So I'll try to kind of divide them out, and we'll kind of take it from there. The first one I have is what has been the research of treating a very specific condition of treating migraines with CBD or medical marijuana? Does insurance cover that? So I can start off by saying that on any painful condition, there is probably some version of trial going on. There have not been a specific trial with the drug, with the CBD version, Epidiolex, with migraine, but a recent trial was started out in the University of California system, where they have used a combination of THC and CBD for migraine management. So we'll see. It's more proof in concept. We don't know how that'll play out. My guess is any pain may have a benefit, but I don't know that. I can't say that for sure. And I'm not saying that I've just gone ahead and told you to use it for any pain. I'm just saying that that's a possibility. But the research is out there. One important point I'd make about that particular issue is, because it mentions, does insurance cover that? When it's a clinical trial, most clinical trials are covered by the people sponsoring the clinical trial. So clinical trials should not really involve insurance for the most part. It typically has to do with the sponsor, because the institution is getting paid by the sponsor to do the trial. So insurance would call that double dipping, unless you're being managed for something else. So oftentimes insurance won't cover it. So stay tuned on the migraine piece. We don't know which of the compounds it is, but it is being looked at from that direction.
Let me just add one other quick thing about clinical trials, which is that one of the challenges now is that people who are effectively self-medicating for whatever condition, using what's available at the state dispensaries or state accredited dispensaries, what they're taking is not something that has been through the federal drug approval process. And so therefore, and insurance will cover things that have been covered by the federal drug approval process. So what happens with a clinical trial is that the study sponsor will cover the cost of the medication for the duration of the trial. Some studies also allow for continuing use to the participants who are part of it. But very often what we'll see happen is that the knowledge will be gained that this drug is beneficial, and then it will get approved, and then insurance companies will decide whether to make it part of their formulary. And if they do, a lot depends on how expensive that drug actually turns out being. And so the epilepsy drug that Dr. Sirven mentioned is thousands of dollars per course of treatment, versus $80 at the dispensary for something else, not the same thing, but for something else in the THC or CBD family. So insurance is never going to cover anything that doesn't go through the federal approval process. And the challenge is so few things are actually going through the federal approval process right now. So this is one of the reasons why I advocate more for recreational use than for going the medical route, because I suspect it'll be decades and decades until we get to a point that we've generated the knowledge that's necessary. But there are thousands and thousands of us suffering today from something that these compounds could potentially help with.
Dr. Robert, I'm going to throw one of these questions for you to comment, then I'll take another. One of the questions that hit, it's interesting. Can you explain a bit on the current law allowing citizens to use marijuana versus not allowing a permanent resident to do this?
Yeah, it just has to do with the fact that according to the federal government, marijuana is an illegal drug. And so if a citizen is allowed to, in a state in which, so this is effectively meant as a state's issue, right, these days. And so if a state like Arizona approves marijuana for recreational purposes, anybody is welcome to, I could go into a dispensary and hope that the Immigration and Customs Enforcement never find out, but I'm not willing to take that risk because I would be effectively in violation of federal law, though in compliance with state law. There was a lot of trouble early on because under some attorneys general, there's been a push to make it very, very difficult for states that have approved marijuana, even merely for medical purposes. It made it very, very difficult for them to do business, for instance, through threat of prosecution, through interstate commerce things, restricting access to federal banks and so forth. And so there's been an effort over the years under certain attorneys general to really crack down on the sense that federal law ought to supersede state law when it comes to an outlawed drug such as marijuana. But things are getting a little bit easier now. Since 2017, there's been a congressional cannabis caucus in the House of Congress, in which there are 4 members. It's bipartisan, 2 from each party. There have been a couple of iterations of this committee. They've been actively involved in trying to harmonize federal laws that are in violation of state laws in those states that have approved the use of marijuana.
Let me go to another question, and I think this is an important one because it underscores a point I want to make. It came with the question: if someone's currently on opioids, anti-anxiety meds, sleeping meds, and cannabis is added for pain, how do these drugs interact? So I wanted to make sure I tackled this one to just say, although we talk so much and there's all these dispensaries out there and it may seem so easy to get than the way it used to be, that's a cannabis in any of its forms and varieties is a drug. And what I mean by that, it can interact with anything else you put in your body. So one of the things I would say is that we know that for certain drugs, CBD has a big drug interaction with a class of drugs called the benzodiazepines. That's the Valium family. That's things of that sort. And those are often used in some anxiety, and they can augment some of that sedating quality to it. It can also have an impact on sleeping meds too, because again, for certain versions, it's very sedating for some. It can also, in some elements, can also have interactions with anticoagulants, which are meds that are used to thin the blood, used in stroke. So one has to be kind of cautious when it comes to it. So if you have medical conditions, so as I'm reading this, if someone has multiple medical conditions, It's one of those things you have to really kind of come clean with your doctor. And it used to be, and I've done this for a while now, that, earlier on, yes, at the moment you said you tried this or went to dispensary, doctors would immediately shut down and be judgmental. Now, not so much. Everyone's pretty, has their eyes open, and it's not shocking. If they do shut down, then it's probably time for another doctor.
That's exactly what I was going to say. That's exactly right. I mean, you need to be crystal clear with your doc what you're taking. And if you're taking, recreational marijuana, or if you've got your medical card, make sure your family doc or your internist knows, so that they can go over some of these concerns, some of these side effects with you. There's one question that came up: is the medical card used for CBD only, or also for other components of the cannabis plants? The medical marijuana card is available for, as my understanding, anything you can buy in a dispensary for recreational use, you should be able to buy for cheaper with a medical marijuana card. That's my understanding of the way it works. You just want to be super careful, because the kinds of things that with medical marijuana, you're typically going to get a prescription for a particular use, but that's not going to keep you from buying other things, and in particular, different formulations. For some people, and the state of Arizona recognizes this with its medical marijuana program. For some people, smoking is a terrible way to provide the drugs to the system, and so vaping might be better, or dabbing, or I don't know, the other methods of administration. And if I understand correctly, in the state of Arizona, you're not allowed to smoke your medical marijuana, at least not in nursing homes or in some of those facilities, but you're allowed to get it in any other form, as long as it's been provided.
I like, one of the things that hit me, I like a couple questions that hit about almost like in the alcohol sense, and maybe I can hear what you think on this, Dr. Robert, has to do with because it's available recreationally and for medication. How does the state or other governments view it if a doctor or nurse is taking this stuff on their personal time? I guess it gets to this question of getting drug tested, and I'm bringing up doctor nurse because that was brought in the question, but that really could be brought up in any place of employment.
Exactly. So federal employees, for instance, federal agents of any sort, people who work for Homeland Security, people who work for the FBI, et cetera, they are not permitted to break federal law. And so they can't get medical marijuana for any purpose, and ought not to be using it recreationally either. Some employers have made it crystal clear that they will not accept medical documentation, but other employers might have a different kind of policy in place. So it's always good to check with your employers, especially if you're subjected to random drug screens. There was one other comment that was made, that there are plenty of drugs that we use for plenty of reasons that haven't been approved either for that particular indication, or in some cases haven't gone through the FDA at all. And so one example would be, various kinds of painkillers, various kinds of narcotics that have been used, and so forth. And so the question is, why can't marijuana be grandfathered in and given a reclassification, since it's not a new drug and it really should be reclassified? That, to me, is the most fascinating aspect of this, is just how resistant the federal government is to decriminalizing or rescheduling marijuana. Marijuana is seen as, by federal regulators as one of those drugs that really is problematic, and therefore ought not to be made available, even for research purposes, which is, super surprising. And just to comment on one last one, I see that there was one participant said research was conducted last year that had participants purchase 10 grams of cannabis with about a 20% THC potency from a recreational dispensary, and then they completed cognitive tasks before and after to assess presumably the cognitive effects of those compounds. That's an interesting situation. It's one of those ones that I'm kind of surprised made it through the institutional review board at ASU, because they seem to be fairly risk averse. But if it's not clear to me whether the PI has Schedule 1 clearance to conduct a marijuana study, but it's certainly the case that if those kinds of studies could be approved, that would certainly be one way to build the evidence base using the drugs that are actually being consumed, rather than the drugs that are being grown for research purposes in Mississippi.
I'm gonna, take another one of these questions, which is having to do on the medical side. Is that, are there cardiovascular concerns with marijuana THC, especially in higher concentrations? So what we know, and again, this is one of those fluid areas to which there's so many journals and so many studies coming out that's hard to know. From the theory standpoint, and again, depends on which of the compounds that you have a predominance with. You can see that the prevailing thought is that a lot of times when you use high dosing of these medications, particularly on the THC side, it can increase blood pressure because it changes the way the tone of the muscles that's embedded within the walls of the blood vessels. And as a result, that can lead to decreased blood flow, particularly to areas in the brain. And so there is at the very high doses of too much, there are theoretical risks of seeing increased strokes. Now, there was a comment, what about population health studies and stuff? We have not seen that bear out. What we have seen bear out from the Colorados and the Oregons of the world is that there has been some more concern about what happens in younger age people who use this. There is, especially if you have a psychiatric predisposition towards things like schizophrenia or anxiety disorders. In some cases, some of these can push you over in that direction if you start too early. So I kind of take a couple of these and just say, we do have to be, this is approved only in the adults, and it is not approved unless you have a specific medical condition for which there is good evidence to use it, like in the epilepsies or something in that direction. It is not approved for kids, so to speak. Dr. Robert, I don't know if you want to add to that.
Just a little bit. There was a question earlier about, if there were states that had purely recreational access to medical marijuana, at what age should people have access to those drugs? And I suspect it's going to revolve around age majority arguments, whether that's going to be 18, 19, or 21, or if you live in one state just this week loosened child labor laws so that teenagers can work 6-hour shifts at night. So maybe, we'll see in some states there'll be a lowering. In Canada, the age majority is 18, and in some provinces, 18 is the drinking age, the legal drinking age, and in others, 19 is the legal drinking age. Of course, in the US, 21 is legal drinking age across the board. If the populace believes that medical marijuana or recreational marijuana ought to be made available more broadly, then I can't imagine it being made available anywhere lower than 18, except with a specific kind of exemption, for instance, pediatric epilepsy, where the kids need the drug at 7 or 8, but they're certainly not taking it recreationally.
Right. There was a comment here I thought that was kind of interesting that I want to kind of also make a point about, and that is about what you find in dispensaries. They mentioned Arizona ones. I'll throw in the ones in other states as well. Let me make a very important point about the dispensary-based element. Although it's out there and there's approvals, to some degree, there's a dizzying array of varieties that are available in every different format you can conceive of, ingest, smoke, whatever. But what I will tell you is that you are also very much at the mercy, and you can, and I can get that adjective or word corrected, of the growers and preparers of this. These are not so, like when a drug goes through the FDA and is out as a prescription, there are very explicit laws that say it must be XYZ is in that pill, and it has to be in this formulation and things of that sort. When it comes to the dispensary world, the regulation is much more lax. So you have to almost trust the grower, if you will, and the preparer that it's good stuff. Not too dissimilar, if I wanted to take a more benign thing, to Dr. Robert's maple syrup in Canada, or to olive oil in Italy. There are, when it's good, and you know who to trust, and or at least you think you do, because they're charging you the prices. My point in this is that whatever they say is in there, you have to have a sense of faith that they're telling you what it is, because there's regulators don't go in there and test every version of this. It's kind of like a restaurant and a recipe. It's in the eyes of the beholder. Dr. Robert, correct me if I'm wrong.
No, you're absolutely right. And so, there are, of course, groups available through social media sites that, or through Reddit in particular, where you can learn more through patient experiences or people's experiences with both dispensaries and with products and so forth. And, the trick at the end of the day is to find a trustworthy bud tender who's actually going to help you dial in on specifically the kind of effects you're hoping to see. So, for instance, if your ambition is to find a strain of indica, or a hybrid strain with a higher proportion of indica, so that you end up with that full body sensation rather than the sort of more psychoactive sensation that you'd have with the higher THC product, then and the reason that you want that has to do with whatever particular symptoms you've had, or particular experiences you've had, or particular sensations you're hoping to have. The trick is always going to be to find somebody you can trust who can help you dial in on that. Turns out the folks who run these dispensaries, especially those who grow their own product, know way more about this than just about anyone else in the world, including in Congress. And let me just step back to a question from Dr. Mirko about how we might advocate for rescheduling marijuana from Schedule 1 to Schedule 4, say, in order to advance the research. Well, there has been a bill passed by Congress called the Cannabidiol and Marijuana Research Expansion Act that was approved in 2022, that is taking some steps potentially in the direction that we need to go to facilitate further research. But so far as I know, there's still no indication of a willingness to consider rescheduling marijuana. And so I suspect what we're going to end up seeing happen is there will be eventually sufficient medical evidence of the efficacy and safety of THC and CBD for particular medical conditions, that the disclaimer attached to Schedule 1 drugs that they have no medical purpose, which distinguishes them from Schedule 2 drugs, that disclaimer is going to have to be dismissed, in which case it ends up being, marijuana would end up being subject to potential rescheduling, maybe simply as a Schedule II drug. But as a Schedule II drug, it becomes a lot easier to conduct the kinds of studies. And also, as I said before, there was a push about 5 years ago to make it possible for growers to apply for their particular strains to be used for research purposes with federal approval. And so rather than just that one stockpile in Mississippi, although that center still needs to grant approval to those growers, but we could eventually see an expansion of access to dispensary grade marijuana that could be useful for research purposes, and then also for clinical and civilian use.
One of the other questions, it looks two questions kind of pertain, kind of allied to each other, having to do, given the federal regulations on this, how does that apply to the world of veterans?
It's a great question. I don't know the answer to that straight off, although I will point out that the VA has been a very strong proponent of research with medical marijuana, research using medical marijuana on veterans, especially veterans suffering from post-traumatic stress and other kinds of conditions that are still poorly managed and dramatically debilitating for our veterans.
Yeah, because I was thinking, like, in general, that is something that has opened up more than I ever thought was possible in that group. So I don't know what it means on the day in day out right now, but certainly if there have access to trials, that would be one of those elements there.
Yeah, and the VA in Phoenix has been actively involved, as well as in Tucson.
I'll throw one other one here, and I think it's very related to what I've addressed before, but is there a chance that when multiple meds are used with cannabis, can they cancel each other out? Answer is of course. It's again, it brings out that whole larger issue of drug interactions. This is not a drug that you put in the body and doesn't interact with stuff. It interacts with tons of meds. So the smartest thing is that if you are on other medications, ask the physician, ask your primary care, ask whoever you see, is this okay? Look it up, ask the question after you look it up. That I think will be very, very helpful when it comes to kind of addressing that. Just as remember, they're not, just because it's all out there doesn't mean it's innocuous, and it's not like eating M&Ms. Even that you get calories for. So yeah, there's always a price to pay with something in that direction.
I don't have anything else to say. We've gotten through all of our questions, I think, and so I'm grateful to you all.
I think that I am most grateful as well. This has been a terrific conversation, and I just loved hearing all the dialogue that came up from it. So that's all the time that we have for today with this. I will say that we encourage everyone out there to follow the College of Health Solutions on social media. The social media channels are on the screen, as you'll see down there. The Twitter handles ASU Health. On Facebook, Instagram is ASU Health Solutions. So check them out. There's a lot of good stuff out there to follow, a lot of great information. Our Health Talk series will continue in September. I can't believe we're talking about that already, but in September is the next time. Details and registrations for upcoming Health Talks will be available at asuhealthtalks.com. On behalf of Dr. Robert, myself, the College of Health Solutions, thank you all for attending today. I hope you have an amazing rest of your day and hope you've enjoyed the presentation.